Good evening, everyone. Welcome to the 2021 SMSNA Virtual Residence Arena. Thank you so much for all of you for joining us this evening. I'm really excited to hear some presentations from our top 10 submitted resident abstracts to the meeting this past year. And so tonight, joining me to moderate and judge these these presentations is Dr. Lawrence or LJ Jenkins and Dr. Rachel Rubin. And so the way things are going to work this evening is each resident will have 4 minutes for their presentation, followed by 1 minute for questions. So everybody please try to stick to time. And all of our audience members joining us, you'll have the ability to put questions into the Q&A if you'd like to ask any of the residents a question, and we'll be monitoring that to report them at the end of the session. In addition to that, I think I just look forward to hearing everyone's presentation, and I'd like to wish all the residents good luck, and we can get started with our first speaker for the evening. So remember, everybody, there's 3 prizes on the line this evening, $1,000 each. No pressure, guys. I'm sure you're all going to do great. So our first speaker of the evening is Dr. Avery Braun from the Einstein Healthcare Network, and she's going to speak about her innovative findings characterizing the location and severity of post-operative pain following inflatable penile prosthesis surgery managed with multimodal anesthesia. That was a mouthful.
Yes, it is. Does everybody see my screen and hear me okay? I see some thumbs up. Thank you very much. All right, everybody, thank you for the introduction. My name is Avery Braun. As introduced, I'm from Einstein Healthcare Network in Philadelphia, Pennsylvania. Thank you for this opportunity. Here are our disclosures. The opiate epidemic and the role surgeons play as prescribers continues to be a serious public health concern. In urology, numerous initiatives have been made to curb opiate prescribing, a majority focusing on alternative methods like non-opiate medications. Considering this, the creation and implementation of multimodal analgesia, or MMA, emerged in the past several years in prosthetic urology. Published data from our own institution with external validation has found the use of MMA as an effective means for postoperative pain control in the IPP recipient. Nevertheless, many implanters argue that surgical approach itself, be it penoscrotal, infrapubic, or subcoronal, lead to different levels of pain during the recovery process. Specifically, proponents of infrapubic and subcoronal technique argue that with minimal scrotal manipulation, the pain symptoms following surgery is reduced compared to penoscrotal approach. However, no center to our knowledge has critically analyzed, defined the severity of location, duration, or the best management of postoperative pain following any IPP surgery. As a result, we carried out a prospective questionnaire analyzing postoperative pain following penoscrotal IPP surgery throughout the first month of recovery, with the use of our standardized MMA protocol as listed here. This series was a single institution prospective analysis by a single surgeon at an institution with large experience in penoscrotal inflatable penile prosthesis surgery. We included only primary IPP recipients via this approach from September 2019 to August 2020. Our questionnaire was thorough and laborious through the time plans listed on postoperative 2, 7, 14, and 30. We aim to better understand and characterize the pain through the questions listed here. This graphic shows the breakdown of patients included and excluded. Excluded were complex cases, history of chronic pain, chronic narcotic use, or alternative approaches. Here is a graph where we look at the region of most bothersome pain at each interval check-in. I want to draw your attention to the fact that while scrotal pain in the top blue was a third of the patient's pain, a majority of the pain that the patients reported were outside of the scrotum. Here we look at a pictorial schematic of the region of most bothersome pain in a different way. I want to draw your attention here that only the penis, the shaft and the glands increased significantly over time, from 17% on postoperative day 1 up to 31% on postoperative day 30. This did reach statistical significance. Here we stratified patients by pain in the listed categories based on their visual analog pain scores from none to mild, moderate, and severe. We observed a statistical significant trend over time with increasing patients reporting mild pain, increasing from 23.1% on postoperative day 1 to 70.4% on postoperative day 30. This is with severe pain decreasing over time from 46.2% on postoperative day 2 to 11.1% on postoperative day 30. Important to note, you can see on postoperative day 14, we reached a threshold where 50% of our participants reported no pain. Furthermore, their pain scores increased or decreased statistically significantly throughout the postoperative period. However, when specifically looking at a region of pain, penile shaft and glans were the only region where the VAS scores increased over time instead of decreased as listed here. In closing, we presented the first descriptive analysis of its kind, where we looked and did a rigorous descriptive analysis of the pain profile experienced by penoscrotal primary IPP recipients over the first postoperative months. We feel that specifically the findings help support our belief that while proponents of infrapubic and subcoronal approaches anecdotally postulate that decreased postoperative pain due to reduced scrotal manipulation is a thing, we did not find that in our series. We found objectively and demonstrated that most penoscrotal IPP recipients had well-controlled pain with MMA, but those that did have severe pain or complaints throughout the postoperative day periods were more likely to complain of penile shaft and glans pain. Thank you.
Thank you very much, Avery. We've got any questions from our audience or my fellow moderators?
So how would this change your clinical practice?
I don't think it'll change our clinical practice specifically in the sense that we do penoscrotal in a majority of our patients, but I think what would be interesting is we're moving forward to try to collect patients that we have done infrapubic on or work in a multi-institutional fashion where we compare the pain profiles experienced with the different approaches to really have a better understanding of if they have different profiles and if that factors in. I think that this, in general, we've been focusing on how we reduce opioid use and narcotic dependence in prosthetic urology, but we haven't done a good job really defining the pain profile seen. So I think this just helps us better understand what the patients experience and how well MMA is working.
Thank you very much, Avery. All right, Lindley, are you all ready to go?
Hi, yes.
Welcome.
Hi.
All right, so Lindley Diao, I'm sorry, is that how to pronounce your last name?
Yeah, good job.
From UT Southwestern Medical Center is going to speak on when to suspect artificial urinary sphincter cutoff erosion, an analysis of presenting signs and symptoms. Take it away, Lindley.
Okay. Can everyone see my screen? All right. Thank you for allowing me to present today. I will be discussing on artificial urinary sphincter presenting signs and symptoms. These are our disclosures. So, as we all know, artificial urinary sphincter is the gold standard for surgically treating male stress urinary incontinence. However, urethral cuff erosion remains one of the more common and most devastating long-term complications. Most literature on cuff erosion focuses on the risk factors, but less information exists focusing on the presenting signs and symptoms, which is paramount in timely identification of erosion and facilitating intervention prior to further complications. Our primary objective was to characterize the most common presenting signs and symptoms of cuff erosion, as well as their frequency, and to look at risk factors for cuff erosion in our cohort. We performed a retrospective review at our tertiary center and found 893 cases in our AUS database from 2007 to 2020. We identified those with cuff erosion. We also used a non-erosion control group. Demographics, comorbidities, and risk factors for cuff erosion were all collected. The presenting signs and symptoms were then classified as either obstructive symptoms, worsening incontinence, or scrotal inflammatory symptoms. Note that patients were counted in more than one group if they had more than one symptom. So in terms of our results, of the 893 patients in our database, 6.8% of patients presented with cuff erosion. The most common presenting symptom group was scrotal inflammatory symptoms, followed by obstructive symptoms and worsening incontinence, as shown in our Venn diagram. Note that the patients were presenting with 2 out of 3 or even 3 out of 3 symptom groups at times. More overlap existed between the scrotal inflammatory and obstructive symptom groups. In the non-eroded control group, from the office notes from the most recent follow-up visit, the majority, 90.2% of patients, had no complaints at all and had either complete continence or very mild incontinence. The prevalence of comorbid conditions and known risk factors for AUF cuff erosion were evaluated in all of the patients. Relative to the non-erosion group, men who eroded had a higher prevalence of pelvic radiation, coronary artery disease, high blood pressure, and smoking. Interestingly, men whose chief complaint was worsening incontinence usually presented significantly later than the other symptom groups. It's unclear why this was the case, but we hypothesize that progressive cuff erosion and worsening stress urinary incontinence only becomes apparent to the patient and or the provider when a certain threshold of bother is reached. Again, this just highlights the results from the last slide. So the demographics and risk factors and treatment history are all here, broken down by symptom presenting category. In the last column, you can see that there is no significant difference between the symptom groups. However, on the third row, you can see that the men who had the chief complaint of worsening incontinence presented significantly later than those with scrotal inflammatory symptoms or obstructive symptoms. And here are 2 representative photos of patient with scrotal inflammatory symptoms. So these patients often had a variety of symptoms, including swelling, erythema, induration, pain along the pump, difficulty palpating the pump. We coined a term pumpitis to describe all of these symptoms. And it's interesting to see that these 2 patients exactly here were found later to have cuff erosion. So in conclusion, the most common early manifestation of cuff erosion are these scrotal inflammatory or pumpitis symptoms. Obstructive voiding system symptoms and worsening incontinence are also common, but less common than the pumpitis. Heightened awareness of this presentation is very important and may allow us to evaluate and identify cuff erosion earlier than before. Thank you for your time. Any questions?
We've got a question from Dr. Yaffe. Was cuff size predictive of erosion?
So we actually did not look specifically at cuff size in this paper. However, that is in our database, and we do use that in our other papers that we've written. We just didn't exactly look at the cuff size in comparison to the most common presenting symptom groups.
All right, we've got another question in the chat. Great presentation. As scrotal inflammation was the most common symptom of cuff erosion in your cohort, was culture data available for assessment in any of the groups? And if so, was it significant?
So yes, we commonly routinely always get culture data. However, we did not add that to our database. That's a really interesting thing that we could note in the future and look at in terms of the cultures and if that's linked at all to the pumpitis.
Great.
Can I ask a quick question?
Sure.
You had mentioned in the beginning, and maybe I missed it, about testosterone. I know there's been a lot of interest in testosterone and cuff erosion. Did your data reflect any changes in testosterone levels for these guys with cuff erosion?
That is an interesting paper that we actually used testosterone and cuff erosion in a different study that we have. So we didn't focus on it in this paper because we have another very similar paper that we talk about that.
All right, thank you very much.
Thank you.
We will move on to our next presentation. I have the pleasure of introducing Dr. Joshua Randolph, who I know very well as he spent some time with me at the Brody School of Medicine in my lab and he's going to present some of that data. He's now a PG1 at the Mayo Clinic in Jacksonville, and he's going to talk to us about some basic science looking at co-cultured Schwann cell rescue to rescue irradiated pelvic neuron outgrowth and increase survival.
All right. Can you guys see my screen?
Not
Yeah.
yet.
So as Joanna mentioned, I'm Josh
Not
Randolph.
yet.
Oh,
Not
sorry.
yet, Josh.
Oh, sorry. That work?
Now you're good.
Oh, okay, awesome. Yeah, sorry about that. So as Joanna mentioned, my name is Josh Randolph. The title of my research is Co-cultured Schwann cells rescue radiative pelvic neuron outgrowth and increased survival. And again, I'm a urology intern at Mayo Clinic, Florida, and this work was done during my medical education as a member of Dr. Hannon's basic science research lab, and I have no disclosures. So radiation is a common and effective treatment modality for prostate cancer, which unfortunately leads to a number of side effects which impact quality of life, including erectile dysfunction. The mechanism for radiation-induced erectile dysfunction has not been fully investigated, but is known to involve radiation exposure and damage to the periprostatic nerves and blood vessels. Such nerves which control erectile function include the inferior hypogastric plexus in humans and the major pelvic ganglion, or MPG, in rats, as you can see in this image, coursing posterior laterally around the prostate and giving rise to the cavernous nerve. Previous studies have shown that radiation leads to neuronal apoptosis and loss of nitrogen neuron density. We've also previously shown that ex vivo MPG radiation diminishes neurite outgrowth in dissociated neurons, but actually enhances neurite outgrowth in MPG neurons that are grown in the presence of their native supporting cells within the MPG, including Schwann cells. Schwann cells are known to facilitate neuron repair after various types of mechanical injury, but the role in radiation-induced injury is unknown. As such, the objective of our study is to investigate the effects of co-culturing MPG neurons with Schwann cells after ex vivo radiation as it pertains to neuron survival, neurite growth and branching, and autonomic neuron density. So we first extracted bilateral MPGs from adult male Sprague-Dawley rats. We delivered either 8 or 0 grade to the MPGs in a biological radiator. We then dissociated the MPGs into neurons and Schwann cells. The Schwann cells were grown to confluence in a selective medium, and dissociated neurons, we ended up plating over them. The groups were separated by radiation status of each the neurons and Schwann cells in co-culture to create 4 groups. The control MPG and radiated Schwann cell group is not shown in this image. And then finally, the co-cultures were incubated for 72 hours and then stained with antibodies against the S100 protein, which is a Schwann cell marker, beta tubulin, a neuronal marker, neuronal nitric oxide synthase, a nitrogic marker, and tyrosine hydroxylase, which is an autonomic marker. We used immunofluorescence to measure neurite growth and branching and to assess autonomic neuron populations. And we also used a tunnel assay to measure apoptosis. So we first confirmed the presence of Schwann cells in co-culture, as you can see by these representative images, the Schwann cells staining purple for the S100 protein. We performed a real-time quantitative PCR, which revealed changes in gene expression after radiation, including downregulation of genes of myelination and differentiation, such as SOX10 and CROX20. But the genes associated with neuronal stress and injury are upregulated, such as GFAP, ATF3, SOX2, and GAP43. And this change is consistent with a shift in phenotype of the Schwann cells from myelination to repair. Using the tunnel assay, we saw that radiation led to increased neuronal apoptosis and decreased total neurons, indicating cell death, which was actually partially mitigated by the presence of healthy Schwann cells in co-culture. We also observed that radiation led to enhanced neurite outgrowth, but only in the presence of control healthy Schwann cells. We saw that radiation diminished neurite branching, which was actually also mitigated by the presence of healthy Schwann cells. And assessing the relative proportions of autonomic neuron populations, we saw that radiation led to a decreased density of nitrogen neurons, similar with our previous radiation studies, that was actually not saved by the presence of healthy Schwann cells. And we overall saw that radiation did not lead to a change and adrenergic neuron density. So in conclusion, radiation causes a shift in Schwann cell gene expression from a myelinating phenotype from a repair phenotype. It leads to increased neuron death, which is partially rescued by co-culture with healthy Schwann cells. And it diminishes proerectile nitrogen neuron populations regardless of the presence of healthy Schwann cells in co-culture. And it enhances MPG neuron outgrowth in the presence of healthy Schwann cells. Future studies are going to be needed to confirm these findings in vivo and determine whether a therapeutic role may be possible. And I'm happy to take any questions. Thank you.
Thank you, Josh. So you have the pleasure and misfortune of having me here because I can ask you some pretty difficult questions since Trinity's not here with us today. So he made the comment during your presentation at SMSNA that this was a very artificial system. Why? What is the benefit of using this artificial system?
Absolutely. And I think that when Trinity asks a question, I typically, it's kind of like a deer in headlights situation, but what I would have answered if I had a cooler head at the time. But my thoughts are that if having this sort of artificial system where, we are providing ex vivo radiation in a controlled situation and controlling their growth, in cell culture, we eliminate all these other variables which create background noise. Most of these studies have been done in vivo, which has led to some conflicting conclusions, such as maybe the damage that we see or the erectile dysfunction is due to vascular effects. Maybe the erectile dysfunction and subsequent other irregularities are due to inflammation or some participation in the immune system. And the truth is it's likely an interplay of all of these factors, but eliminating and controlling for just, the effects seen in nerve damage kind of allows us to assess that single effect and then work backwards from there so that we can kind of use that in conjunction with what we see in vivo. And I think that that's a very useful tool.
All right, thank you very much.
Thank you.
All right, we'll keep this moving. We'll move on to our next presentation. Dr. Bonvadia is speaking on artificial urinary sphincter reverses weight gain associated with post-prostatectomy incontinence.
Looks like y'all can see my screen. Is that correct?
Correct.
Well, thank you for the opportunity to present tonight. I'd like to propose the novel concept that post-prostatectomy stress urinary incontinence may be more than a quality of life issue. Here we report our findings that post-prostatectomy SUI is associated with weight gain and its correction associated with weight loss. So we know that SUI is common after prostatectomy, and studies have shown that it's associated with decreased physical activity. We also intuitively know that decreased physical activity is a risk factor for weight gain. However, to date, there's no study that has identified post-prostatectomy SUI as a risk factor for weight gain. Based on our clinical observation that men with post-prostatectomy SUI complain of decreased physical activity, we hypothesize that persistent post-prostatectomy SUI would be associated with weight gain, and the correction of this SUI with AUS insertion would be associated with weight loss. The clinical implication is that SUI may be more than just a quality of life issue and may be a risk factor for a less healthy life. So our major selection criteria are shown. This was a retrospective single-center study from 2009 to 2020. All patients that underwent radical prostatectomy. AUS patients served as a group of interest and had moderate to severe SUI rated by pad per day usage. Patients who had an IPP placed after radical prostatectomy served as a control group for weight change because these patients had minimal to no SUI, and it allowed us to control for the effect of the additional prosthetics procedure when assessing weight changes over time. This resulted in 187 unique, highly selected AUS patients and 63 IPP controls for analysis. Our first question of interest was whether post-prostatectomy SUI was associated with weight gain. We looked at this in two ways. First, looking at raw weight changes, we found that men who underwent AUS insertion and had moderate to severe SUI experienced a mean weight gain of 3.1 kilograms from radical prostatectomy to time of their prosthetic surgery. Next, we used linear regression analysis to assess whether the greater the severity of incontinence, the faster the rate of weight gain. We found that there was a significant dose-dependent effect. That is, for every pad of incontinence, the rate of BMI change increased by 0.14. meaning that patients with more severe incontinence had gained weight faster. We then asked the question of whether correction of this SUI would be associated with weight loss using a similar two-pronged approach. First, looking at raw weight change, we see that 12 months after AUS insertion, patients experienced a mean weight loss of 4.1 kilograms. Importantly, this resulted in 1/3 of patients meeting the definition of clinically significant weight loss, which is greater than 5% change in body weight. Next, using a linear regression analysis comparing weight change as a function of number of pads improved in incontinence, we found an inverse dose-dependent effect, suggesting that patients who experienced greater magnitude of continence improvement lost weight at a faster rate of 0.15 BMI units per pad improvement in their SUI at 12 months. Finally, we put all of these results together and performed a multivariable linear regression analysis examining weight change 12 months after prosthetic surgery. Our model adjusted for patient comorbidities, including smoking, diabetes, age, and prostate cancer factors, including T status and radiation and ADT usage. We found that AUS insertion was associated with a significant BMI reduction at 12 months after prosthetic surgery by about 2.83 BMI units in the model. Importantly, neither radiation therapy 1 year prior to prosthetic surgery or in the 1 year after was associated with significant weight changes. Similarly, ADT usage 1 year prior to prosthetic surgery and in the year after prosthetic surgery were not associated with significant weight change in our model. And obviously ADT usage is a significant factor in terms of weight gain. In conclusion, post-prostatectomy SUI was associated with weight gain and its correction associated with weight loss. Importantly, 1/3 of patients in this study experienced clinically significant weight loss after AUS insertion. This has the potential implications for patient care, namely that SUI may not just be a quality of life issue and may be associated with worse health outcomes. The limitations are a study that is retrospective and single-centered in nature, leaving it prone to selection bias and confounding, and we lack data on physical activity changes directly. However, this shows the obvious need for future prospective studies examining these questions directly to validate these novel findings. So with that, I'm happy to take any questions. Thank you for your time.
Do you find similar things in the female stress incontinence literature?
So there was one study looking at the insertion of sling, and they did find weight loss. There was basically a continence improvement study that was associated with weight loss. I think it was one study, it was a smaller study, but it did show that. And I think that both our FPMRS team here at UT Southwestern and our recon team here are now looking at this more directly in a sort of prospective fashion, looking at physical activity changes with weight loss trackers and step trackers, which I think is the right move at this point.
Do you think that the male sling data would be similar as well?
Yeah, we were thinking about that. Maybe these guys obviously should have milder to moderate incontinence, and so maybe the effect may not be as drastic. It's hard to say. And I think this initial pilot study, because the cohort was small, our goal was to see if there was any signal worth chasing. And so I think going forward, it's definitely worth looking at to see if this is more beneficial in people that have very severe incontinence or beneficial in all patients with incontinence. Based on that regression analysis we had where we had showed that the greater the magnitude of incontinence improvement and that with the greater leakage you had was both correlated with weight gain and weight loss, I think it's probably most drastic in the people with severe incontinence.
What do you propose is the mechanism for, why this is going to play? Like, is it as simple as the weight of the pads? So they're not having these heavy pads and diapers and later down the line, they're lighter. What do you propose?
So I think, again, looking for the next obvious phase is to look at the exact causality here. But I think based on our sort of clinical observation, we think it's related to physical activity. A lot of these guys come to our clinic and are basically like, I'm so incontinent, I just don't do anything I used to do. And a good corollary as well, what about people that have had hip replacements and things like that? I think the issue here and the difference between our population and that population is that those guys are a more chronic problem. These guys are having severe incontinence that's radically altered their life immediately after surgery. And so I think these guys may have had a good, healthy lifestyle, had surgery, and now are so incontinent that they don't want to do those normal activities that they used to be doing. And that's sort of what we're looking at next step in terms of getting these patients step trackers to see whether the mobility thing is driving this issue. But anecdotally, we think it's related to activity.
Would that change how you counsel your CrossFit patient who comes in with prostate cancer on surgery versus radiation after the last two presentations?
Maybe. I mean, I think it's so weight gain and weight change are so multifactorial. I think it's hard to say, especially from an oncologic standpoint, to say, this may cause this. So I think it's hard to say. I think it's something to consider. I think if you have to sort of give them your continence numbers and sort of say, here's our sort of expected rate of incontinence. But it's hard to balance, I think, the oncologic control with the quality of life changes. But I think it's something to definitely think about and have a sort of shared decision-making discussion with your patient about.
All right, thank you. So we're going to keep moving. We're going to move past Dr. Tanzi. We're going to go to Dr. Erin Jesse on cost analysis of online telehealth platforms offering testosterone therapy. She's resident at the University Hospitals Cleveland Medical Center.
All right, can everyone see my screen and hear me okay? Perfect.
Good.
Thank you. So I'm Erin Jesse. I'm a PGY4 resident at Case Western Reserve in Cleveland, Ohio. Thank you guys so much for this opportunity. This has been really great so far. I will be discussing a cost analysis of online telehealth platforms offering testosterone therapy. We have no disclosures for this talk. We know that the initiation of testosterone therapy is on the rise in the United States, and recently a new player in this market has emerged, and that is direct-to-consumer telemedicine. These are companies that connect the consumer directly with a prescriber to help them obtain a prescription and then purchase testosterone all on their website. There's no doubt that this adds a certain level of convenience. There have been some concerns raised as to whether or not these platforms can offer evidence-based care as well as cost-effective care. This is particularly important when we're talking about testosterone therapy, because we know historically up to a quarter of patients on testosterone therapy have lacked appropriate testing prior to initiation of treatment, and 50% lack appropriate monitoring while on treatment. In addition, even men with private insurance are still paying on average $832 a year in testosterone deficiency related costs. So with these points in mind, we first aim to investigate the evaluation processes as well as the associated costs of receiving testosterone through these direct-to-consumer platforms, and then compare them to the costs of receiving similar care at a tertiary center. Our methods included an internet search to identify these three platforms, which were chosen based on their transparency of practices and prices. Information was gathered from their websites. And then we used our own institution's cost estimator to estimate what similar care would cost for a patient with no insurance, with Medicare, and with one with private insurance. So for the evaluation of testosterone deficiency, the results were pretty consistent across the board. All of the platforms review past medical history, do a laboratory workup, and discuss the risks and benefits of treatment. Here's a review of the labs that are offered. Importantly, all three platforms did offer to test total testosterone, hematocrit, and PSA, while only one specifically mentioned luteinizing hormone. And then follow-up and treatment monitoring was also pretty consistent. All of the platforms offer follow-up labs and visits within 3 to 6 month intervals. But how much does all of this cost? So we first looked at the cost of that initial evaluation for testosterone deficiency. So this includes that initial consultation fee or copay, as well as those labs that were just discussed. We can see that for an uninsured patient at a tertiary center, this is a whopping $1,200. It comes down to about $560 with private insurance and $0 Medicare. Offer a similar initial evaluation for much less expensive, even with private insurance. This ranges anywhere from $165 to $300. And what about the cost of ongoing treatment? So for this, we looked at the price of monthly membership fees, the cost of medication, follow-up visits, and labs. And if we condense that chart down, we can see that this is $1,300 for the uninsured patient, $770 for the private insurance patient, $130 for the Medicare patient. And now in contrast, we can see that ongoing treatment through these platforms is much more expensive, ranging anywhere from $1,500 to $4,200. This study has a number of limitations. First of all, we can't account for any sort of individual provider variability that might exist on these platforms. And in addition, there's several other platforms out there that weren't able to be evaluated in this way. And our cost estimations are very rough. No doubt there's going to be differences in the types of insurance coverage, institutional practices, et cetera. And so in conclusion, these platforms are following at least some of the most important AUA guidelines. That includes baseline testing as well as follow-up and treatment monitoring. And while there may be a cost benefit in undergoing that initial evaluation on these platforms, there does seem to be a higher cost associated with ongoing treatment through these platforms. And finally, healthcare providers, including urologists, should examine these platforms and consider how we can offer those similar benefits, increased privacy, increased convenience in our own practices while still maintaining a high standard of care and minimizing costs for our patients. Thank you so much for your attention.
Thank you. So questions for this, remember everybody can use the Q&A section. And if you insist, you can use the chat as well. But I have a question regarding your talk. So you show these platforms are, providing options for people. How would you advise kind of like your patients who are like, oh, I can go see you, or I can go to this online thing that's more convenient for me? How would you counsel that patient?
So I think it's important to consider the patient. If you have a high-risk patient who cardiovascular screening and close follow-up with PCP, et cetera, is going to be important, then definitely getting your care at a tertiary center where those resources are available is going to be paramount. For the healthier, less complicated patient, I think that wanting of the differences as far as convenience goes, a lot of these platforms offer to mail the medication straight to your door. We as physicians don't always have the opportunity to provide that sort of service for our patients as much as we would like to. So I think, you can kind of weigh those things based on the type of patient that you're treating.
And Erin, Dr. Jesse, are these texting visits? Are they video visits with physicians? Are they with advanced practice providers? Who are the initial and the follow-up visits with?
Yeah, so only one of the platforms offered visits with a board certified urologist. I believe that was Regenix. The other ones just say healthcare providers, so they didn't specify. And I believe from what I can tell on the websites, they're virtual video visits for the testosterone.
And do they discuss sexual function with the testosterone issues? Do they ask questions about sexual health at all?
That I don't know. And that's sort of that provider variability. We didn't get a great insight as to how detailed these discussions are with patients. And so I would assume, if you're seeing a urologist, they may be more apt to ask those questions. But some of that documented.
Okay, great. Thank you. So we're going to move on to our next presentation. Dr. Rohan Bala from Vanderbilt University Medical Center, Impact of Health Literacy on Satisfaction Following Penile Prosthesis Surgery. Dr. Bala.
All right, good evening. Let me share my PowerPoint. Can you guys all see my screen? All right. All right, well, good evening, everyone. I'm Rohan Bala. I'm a PGY4 at Vanderbilt University, and I'd like to thank you all for letting us present our work today on the impact of health literacy on satisfaction following inflatable penile prosthesis surgery. I have no conflicts of disclosure. So we know that adequate health literacy is required in order to successfully navigate the healthcare system, communicate with our healthcare providers, and make truly informed treatment decisions. Studies have shown that poor health literacy and lower education levels have been associated with increased complication rates, increased utilization of discharge services, differences in quality of life, and a decreased understanding of clinical information. However, no one has really studied the impact of health literacy on patient satisfaction and outcomes following IPP surgery. So our objective was to determine if a patient's health literacy impacts patient satisfaction following IPP placement, and whether or not patients would undergo IPP surgery again if given the choice. We hypothesized that men with lower health literacy, as determined by the brief health literacy screen, are less likely to be satisfied after IPP surgery compared to those with higher health literacy. The brief health literacy screen is a validated tool that is used in our hospital, and it's administered by all healthcare professionals when they're admitted to the hospital prior to surgery. It consists of 3 questions, as you can see there, and patients are given an aggregate score ranging from 3, which is the lowest score, to 15, which is the highest score. We conducted a retrospective chart review of patients that had undergone an IPP surgery between 2016 and 2020, and conducted a phone questionnaire between October 2020 and January 2021. We identified a total of 192 patients, and patients were excluded if they refused or were unable to complete the phone questionnaire, they were unable to be contacted, or if a new implant wasn't placed at the time of surgery. Our final cohort consisted of 162 patients. The satisfaction questionnaire consisted specifically of 2 questions. 1, were you satisfied with your surgical procedure? And 2, if you could go back in time, would you still have agreed to undergo the prosthetic surgery? We conducted ordinal logistic regression using both univariable and multivariable models. So we found that the median age of our cohort was approximately 64.5 years. The vast majority of them were Caucasian and had a history of a prostatectomy. The median preoperative shim score was around 3, and the median BHLS score was 15. About 12.4% of our patients had a postoperative complication, with about 6.8% of those requiring a surgical intervention. We found that the median time from surgery to the phone questionnaire was about 2.4 years. 94% of our patients said that their IPP was currently functioning at the time of the questionnaire. However, only 77% of patients stated that they were actively using it. Approximately 70% of patients stated that they were either satisfied or very satisfied with their prosthetic, and 74% of patients stated that they would undergo surgery again if given the choice. On multivariable analysis, we found that BHLS score was statistically significant for both patient satisfaction and redo surgery. So in conclusion, we found that men with lower health literacy are less likely to be satisfied and are less likely to undergo IPP surgery again if given the choice. We believe that the BHLS score can aid in identifying patients who would benefit from individualized preoperative counseling in order to try and improve patient satisfaction and potentially reduce health disparities. Finally, some of our limitations include the small cohort, the retrospective design, and the potential recall bias associated with our phone questionnaire. I'd like to thank my mentors and my colleagues who helped me with this project, and I'd be happy to take any questions. Thank you.
I have a question. So if you have a health literacy issue, then could you conjecture that potentially there was a sexual medicine, a sexual literacy issue as well, and maybe how sex works may be a little controversial and not always known, and maybe there's a partner issue from time to time? Can you?
Yeah, absolutely. I think you can extrapolate that. I think the questions that we basically looked at were baseline, just general health literacy. We actually looked at other studies at our institution looking at, how well patients understand the shim score. We actually didn't find any difference with like patients who were administered written or verbal, but I do think you can extrapolate that patients that have a lower health literacy probably have a lower health literacy in regards to sexual health literacy.
Any other questions? We've got a shy group tonight, everyone. We've got, over 100 people on and no one's talking.
Here's a question from the chat. Great talk. Did you consider using a validated questionnaire for assessment of the satisfaction with the penile prosthesis? Why choose a 2-question phone questionnaire format?
Yeah, that's a good question. So we specifically chose the 2 questions because we used the Likert scale, which has been validated to show patient satisfaction for in that scale regard. But we kind of just chose to see if, just because a patient was satisfied didn't necessarily mean that they would agree to undergo the surgery again. And that's why we put that question in there on purpose. I think it would be interesting to do a different questionnaire to see on their patient satisfaction, but yeah.
Somebody asked, do you think that surgeons can make up the gap by extra special counseling for these types of patients?
Absolutely. I think, prospective design, looking at how surgeon counseling affects patient outcomes is something that we need to do. in Tennessee specifically, we know that there's a health literacy gap with our patient population, and I do think it can make a difference.
And another question from the chat, what would be the best time to offer this survey?
Sorry. I think you'd have to look at, so we specifically that's why we did the time from questionnaire to the time from surgery, which was about 2.5 years. I think it gives patients a time to not only get used to the device, get out of the postoperative time frame. I'm not sure the perfect time to actually do that satisfaction questionnaire. It'd be interesting to look at how satisfaction changes over time. So that would be an interesting idea too, but I guess I'm not sure the perfect time.
Wonderful. We'll go on to the next speaker. I would argue the perfect time might be 2 months after starting vaginal estrogen on the female partner, if I had to guess. So the next wonderful presentation so far, I'm going to get started with the next. Dr. Williams is going to be talking to us about the urethral microbiome during inflatable penile prosthesis placement. So share your screen and take it away.
Good evening, everybody. Can you see my screen? All right, so I'll be presenting my presentation, the urethral microbiome during inflatable penile prosthesis placement. My name is J. Matt Williams. I'm a PGY4 resident at Ochsner in New Orleans. I have no disclosures. So Foley catheter placement prior to IPP implantation permits drainage of the bladder to ensure safe retropubic reservoir placement. And it also allows for palpation of the urethra to prevent inadvertent injury. The urethra is often colonized with commensal organisms, mostly concentrated at the meatus and fossa navicularis, to which the Foley catheter is exposed during placement. Organisms isolated during previous studies include species of staph, strep, Corynebacterium, Campylobacteria, Escherichia, Klebsiella, as well as Enterococcus, among others. Following placement, the catheter remains on the sterile field during surgery. As we all know, infection is the most catastrophic complication in penile implant surgery, as it requires explant, which carries significant morbidity. Numerous measures have been employed to prevent implant infection, including optimal perioperative antibiotics, improved surgical technique, proper patient selection, as well as optimal prepping. However, the overall goal of these measures is to eliminate bacterial contamination in the operative field, thus preventing device infection. So we investigated if anterior urethral organisms could contaminate the surgical field following Foley catheter placement during IPP implantation. So we retrospectively reviewed data on all patients who underwent 3-piece IPP implantation at a single institution from February of 2020 through September of 2021. As a standard at our institution, all patients received vancomycin as well as gentamicin antibiotic prophylaxis preoperatively, and then they underwent a 10-minute betadine scrub followed by a chlorhexidine scrub. Once the patient was prepped and draped, a Foley catheter was placed, and we collected a culture swab from the fossa navicularis, as well as the exposed Foley catheter. We then assessed growth of aerobic, anaerobic, as well as fungal organisms. 60 patients were included in this study. All surgeries were performed via penile scrotal approach by a single surgeon. The median age of our cohort was 67 years with a range of 42 to 79 years. And 35% of patients had an obese BMI. 42% of patients were diabetics and 7% were smokers. And 20% of patients underwent revision surgeries, all of which were due to mechanical device malfunction. 3 patients or 5% had isolation of aerobic organisms, and 5 patients or 8% had isolation of anaerobic organisms on their culture swabs. No patients had isolation of fungal organisms. A variety of organisms were isolated from their urethral swabs. Notably, there were some virulent organisms such as Enterococcus as well as ESBL Klebsiella isolated. Univariate analysis, statistical analysis was performed and there was no statistically significant relationship between obesity, diabetes, current smoking, or circumcision status in the isolation of organisms. Unfortunately, 3 patients, or 5% of the cohort, ultimately developed a device infection during the study period. Regarding infection risk factors, the first patient underwent a revision surgery in which he had repositioning of his pump with a wound washout. This was a Mulcahy washout. However, the entire device was not exchanged. Second patient was a current smoker and he was obese, and the final patient was also obese. Interestingly, none of these patients had isolation of organisms from their culture swabs at initial implant. Implant cultures grew Klebsiella, E. coli, and the anaerobe Fusobacterium. So in conclusion, 7 patients, or 12%, had isolation of aerobic and or anaerobic organisms from their culture swabs. Despite these organisms being present on the catheter and surgical field, none of these patients have currently shown evidence of a device infection. So these data suggest that there is a risk of exposure of anterior urethral organisms to the surgical field. However, that risk does not increase the overall risk of device infection. However, further study is needed as this study is currently underpowered to make a definitive conclusion. Thank you, and I'll take any questions.
I may have missed it, but were patients giving any preoperative antibiotics as far as like in the days preceding the surgery, or was it just pre-op the day of?
It was just preoperative Vinc and Gent. They were not given antibiotics in the days leading up to the surgery.
Were there postoperative antibiotics given as well? I might have missed that.
Yes, as a standard, patients receive 2 days of decloxacillin if they're a virgin implant. If they're a revision procedure, they receive 30 days of decloxacillin. If they're penicillin allergic, they receive Bactrim.
And we've got a question from the group. Was the vancomycin and gentamicin 100% infused by the time the Foley was placed and the swabs taken? Did all these patients also have a negative urine culture prior to the implant?
Yes. So, as a standard at our institution, patients receive 2 large bore IVs in pre-op, and we ensure that their antibiotics are completely infused prior to prepping the patient. And then regarding urine cultures, we have a preoperative clinic in which patients visit. We always get a urinalysis prior to surgery. And if their urinalysis is abnormal, we'll send that urine for culture and pre-treat them prior to the surgery.
And somebody else said, fascinating that none of the 3 infections had positive urethral cultures. Perhaps colonization is not the issue. Any plans for further research in this area?
Yes. So, I think, we're definitely going to continue our patient accrual with this study. And, I think the take-home message with this study is that, while these patients may be colonized in their anterior urethra, and these bugs are exposed to the sterile field during surgery and to the Foley catheter, it does not pose a significant infection risk, even though these bugs are exposed to the implant potentially. So I think that was really the take-home message.
And from the famous Dr. Faisal Yafi, do you change gloves or do you do any catheter prep when placing the Foley?
That's a really good question. So really the idea of this study stemmed from, there was a chapter in Hinman's about IPP placement, and they describe prepping the catheter with chlorhexidine. And, one of our other residents on the study went to our program director talking about, is this really even necessary? So that was really what stemmed this study, but we don't prep the catheter after placement. We kind of do a semi no touch technique where after prepping and draping the patient, we'll place an ioban on the field and bring the penis through the ioban, but we don't prep the Foley catheter.
maybe I missed this. Did you remove the catheter at the end of the case, or do they go home or stay overnight with the catheter?
So some patients had a same day discharge, some stayed overnight. But if they have a same day discharge, they'll have the Foley catheter removed in the clinic the next day. And if they're staying overnight, they'll have the Foley catheter removed when we see them on rounds the next morning.
Dr. Yaffe says that he shamelessly puts iodine in the urethra before putting the catheter, as taught by Dr. Hellstrom. I learned the same from Eugene Rhee, so we call it our voodoo swipe with the iodine. Dr. Kohler says while you are at it, probably should check nasal swabs, as this has been shown to increase the risk in ortho, although with different bugs. Dr. Ashley Winter talks about this a lot as well. Do you do any nasal swabbing?
We do not, but I think that's certainly probably our next step. I know in terms of the sacral neuromodulation literature, they do nasal swabs looking for MRSA. I think the same thing could probably be applied to the IPP literature, and I think it's certainly ripe for research.
All right, since my group has had the most questions so far, I'm going to stop questions there, and we're going to go to the next speaker. We are going to hear from Janice Owens-Walton. She's going to present on decreasing intraoperative narcotic use, pudendal nerve block prior to inflatable penile prosthesis implantation. You are muted, Janice. Are you there?
All right, can you hear me and see my screen?
Perfect.
Wonderful. So good evening. My name is Janice Owens-Walton. I'm a fourth-year medical student at the Medical College of Georgia. Thank you to the SMSNA for having me. And we will be discussing ways to decrease intraoperative narcotic use by utilizing a pudendal nerve block prior to doing an inflatable penile prosthesis implantation. So I have no disclosures, only that I'm a poor MS4, so I'm clearly not paid by any company. And the only conflict of interest this evening is my bank account and my urology residency application. So please hire me and I can take care of that. A bit of background: Americans use about 80 to 90% of the world's oxycodone and hydrocodone and 65% of the world's hydromorphone, despite only consisting of 5% of the world's population. Drug overdose deaths involving prescription opioids rose from 3,442 in 1999 to over 17,000 deaths in 2017. Trends in chronic narcotic use have been linked to iatrogenic administration of medications within the perioperative period, which creates a pipeline for abuse of prescription drugs and potential transition to illicit drug use. If we as physicians are to do no harm, how do we avoid exposure of our patients to unnecessary doses of narcotics, especially in a veterans population who often suffer from chronic pain syndromes and/or psychiatric substance use disorders? We began to examine alternate methods of pain control and hypothesized that if we utilize a pudendal nerve block, which is often used in obstetric procedures, it might be an effective way to decrease pain perception in the intraoperative period and ultimately decrease the overall amount of narcotics used for the period. Our cohort consisted of 122 VA IPP patients undergoing an infrapubic insertion of the IPP by a single surgeon. We excluded revisions, reimplants and explants, and concurrent procedures. We did not control for post-op multimodal analgesia, and patients received pain control at the discretion of their acting provider. Pudendal nerve blocks were delivered in 35 patients, 10 cc's of 0.25% Marcaine without epinephrine and Solumedrol administered in a standard fashion in frog-leg positioning. We examined baseline characteristics of the patients, as well as their comorbidities, including diabetes, hypertension, cardiac disease, and the preoperative use of opioid analgesia. Of the 122 patients and the 35 that received a pudendal nerve block, 87 or 71% were without. Both cohorts had similar baseline characteristics with no statistical difference between the age, race, patient BMI, or the comorbidities. Preoperative analgesia use was percentage-wise higher in the pudendal nerve block cohort and lower in the non. Interestingly, the cohort that received a pudendal nerve block had a lower estimated blood loss and operative time. But most importantly, the graph to the right visualizes the intraoperative and postoperative narcotic requirements for each group. If you look on the left side of the graph, you'll see that intraoperative requirements of the group that received the pudendal nerve block was only 16.3 morphine milliequivalents compared to those that did not at 26 morphine milliequivalents, while there was no significant difference seen in the postoperative analgesia requirements. Now, while we could blame our anesthesia colleagues for what happens behind the drapes, it is our responsibility as urologists to understand how urologic surgery, especially an elective procedure, utilizes narcotics. There are a few big takeaways from the study, the first being that we may be overutilizing narcotics within the intraoperative period. If we can decrease the need by 40%, that's a significant opioid exposure that can be eliminated for a very susceptible population. Second, our postoperative analgesia remained unchanged, whether narcotic or non-opioid. And while this could be considered a disappointing data point, I think it begs a deeper dive into the post-operative pain management protocols that exist within our VA system. And it leads me to question whether post-operative pain management is provider-driven by habit or patient-driven by experience. If we institute a multimodal analgesia protocol specific to IPPs and a pudendal nerve block for all patients across all providers, we may see a statistical difference in narcotic use over the entire operative course, which leads me to think we need a larger prospective study. I'd like to acknowledge my mentors and faculty members and residents who have been amazing at the Medical College of Georgia. And I thank you for your time, and we'll take any questions.
Thank you so much. It sounds like you and Avery can get together and change the world of penile implant postoperative pain. Any questions? Come on, you guys, let's get some more questions going. LJ, you look like you have a question.
Yeah, I have a question. So was there any communication between the surgical team and the anesthesia team regarding the use of intraoperative pain medication?
So the kind of impetus for the project began when one of the anesthesiologists spoke with Dr. King about not having to use as much intraoperative narcotics when she did this procedure. And so that's how we determined that it was maybe something that we should look into deeper and put some kind of data to this kind of random phenomena and see if it's a one-off or whether this is actually a trend that we can change.
I will say at our VA, they let us use Exparel, which is very exciting. And it's been remarkable doing these pudendal nerve blocks, and these guys go home the same day and they are so much more comfortable. So I wonder if the more prolonged, I know we argue about Exparel and the cost and the issues all the time among each other. Another question, awesome and novel presentation. Vote for Janice. The half-life of Marcaine is only about 2 to 3 hours. Have you considered a similar study with Exparel due to its half-life closer to 24 hours? I swear I didn't say that before I read that question.
Again, and this kind of goes with what you were saying, Dr. Rubin, as Exparel does have a longer half-life and would ideally, theoretically show better post-operative pain management. The problem is that it's expensive. From my best understanding, the VA in Augusta is not too excited to use Exparel. However, if we were to use it maybe in a cohort at the university hospital, we might be able to see some differences.
Dr. Rahim is asking, is the pudendal nerve block done by the urologist or the anesthesiologist?
Done by the urologist.
Great question.
Can you comment on how that pudendal nerve block is done? Is it feeling, or is there ultrasound guidance? What do you guys do?
So we place the patient in frog leg, and it's not ultrasound guided. From my best understanding, we're looking for the ischial spine and using 2 fingers, one to move or feel for the urethra and the other to feel for the ischial spine, and then aim between the 2 for the pudendal canal for the pudendal nerve block.
Somebody asked, Mona Abraham asked, great presentation. Was there any difference in the post-op pain level of patients in the two groups?
No difference in no difference in post-op narcotic requirements. But again, I wonder if that's because we did not control for postoperative analgesia. And I wonder if we were to institute an IPP protocol specific, that we'd see maybe patients weren't using as much analgesia.
Dr. Yaffe is reminding everybody to get online and go to the VJPU because there is a wonderful video on pudendal nerve block, and I've been able to teach my residents with that as well. It's really wonderful, and they're big believers now. All right, I think we'll go on. Thank you so much. I think we'll go on to the last presentation of the evening, unless our last presenter has, the other presenter has shown up. Dr. Campbell is going to be talking about, does revision without replacement increase infection risk in urologic prosthetics? Take it away, Dr. Campbell.
Excellent. Can you guys see my screen okay? All right, thank you so much for the opportunity to speak.
Switch,
tonight.
wait, Dr. Campbell, switch to presenter mode. Swap your display.
Perfect. All right.
You're perfect.
Thank you for the opportunity to talk about this research tonight, and thank you also to everybody for tuning in. Today I'll be discussing a project that I worked on to determine if it's safe to revise urologic prosthetics without exchanging any of the components. So these are our disclosures. So prosthetic revisions come with a higher rate of infection than virgin implant surgery. Typically, virgin implants of both AUS and IPPs, perioperatively rates have been reported to be as low as 1 to 3%. However, for revision surgery, this is often quoted to be more around 10%, and studies have shown even as high as 18% perioperative infection rate for revision surgery. And it's unclear exactly why this is, but many theorize that after the initial surgery, a biofilm of bacteria develops that's clinically silent and doesn't cause any problems until you go back for a revision. And at that time, you manipulate and disrupt the bacteria, and that leads to seeding of infection. So two major strategies have been developed to reduce the risk of infection at the time of implant revision. Number one is antibiotic washout protocols, which at this point are nearly universal, and they mechanically disrupt biofilms and then chemically can kill bacteria. And number two is exchange of device components. So taking out the entire component, a biofilm presumably with it, and replacing it with a new device. But we looked with this study, can you perform a revision without taking out the components that you manipulate, or does that lead to a higher risk of infection? So the specific revisions that we're looking at in this study is a minority of the overall revisions that are performed at our center and across the country. These are surgeries where you can think of them more as repositioning rather than remove or replace or true revisions. For example, a patient that comes back with a high riding pump, but otherwise a well-functioning device, or a patient with a herniated reservoir balloon or cylinder. These are surgeries where you reposition different device components, but potentially could get away with not exchanging them if it's not associated with a higher risk of infection. So we performed a retrospective cohort study over the past 20 years at Duke University. We compared two groups, implant revisions, AUS and IPP, that involved exchange of any or all components. The vast majority of these were complete removal replacement, although some were just remove replace of one or two of the device components, versus revision without exchanging any components of the device, the essentially repositioning revisions that I was discussing. Our outcomes were, in fact, revision explant-free survival, aka overall device survival. So our primary outcome, infection at 12 weeks, 411 patients that underwent revision with exchange of components had at least 12-week follow-up, and there was a 2.4% infection rate in that group. And 45 had revisions without exchange of any components, and only 2 developed infection. So there was no statistical significant difference between the 2 groups on t-test. And when we looked at development of infection at any time point, there was also no difference, with a median follow-up of 2.8 years. Finally, we looked at infection-free survival, and you can see this as the Kaplan-Meier curve on the bottom left. There was the red curve is without exchange of components, and the blue curve is with exchange. And again, there was no difference. And when we looked at revision or explant-free survival, essentially device survival, we found the same thing, that these revisions without exchange of components tended to fare just as well. So in conclusion, we think that this data suggests that in the right clinical setting, repositioning device components without replacing them is not associated with an increased risk of infection, and bringing a pump down in the scrotum or repositioning a herniated reservoir or cylinder is likely safe as long as the patient and situation is appropriately selected. Thank you, and I'll take questions.
I assume that was survival of the device and not survival of the patient.
That's correct.
Dr. Yaffe says this is important data. What if there is a fluid leak from the system? For example, if there is a break in the tubing or pump, would you recommend exchange of a single component or all components?
That's a really interesting question, and actually one that we basically didn't address because we, so in that situation, you need an exchange of at least one component. And for the purposes of our study, we grouped complete removal and replacement and removal in exchange of just one component. We grouped them together. We do have a database that has all that data, but we would have to look back and group those remove and replace of all components and remove and replace of just one or a few components and see if there was any difference. But unfortunately, we didn't look at that with this study.
Now, did you guys look at antibiotic use kind of perioperative period in this protocol? I don't think you mentioned that, or I missed it.
No, and the series is essentially over the past 20 years, so it's changed significantly. So currently our standard is essentially 5 days of postoperative Cipro or Bactrim and Augmentin if they can't take either of those, and perioperative or preoperative antibiotics tailored based on culture. So, but that's definitely evolved, and we did not specifically look at that.
Dr. Len says we consider single component exchange unless the device is more than 3 years old, then we exchange everything. Okay, well, I think we've gained more participants towards the end of this webinar. So I think that means some people have called in family members to vote, as well as Twitter followers, perhaps. So is this, Haley, do we have thumbs up to get started on the voting situation here? Everyone give thumbs up to Haley and Tessa here for putting on such an incredible webinar and for all the speakers. All right, so here is the plan. Everybody should have had a poll just pop up. Panelists, you're not allowed to vote, and we are not allowed to vote either. And you're going to pick up to 3 presentations that you want to win, and it's $1,000 per resident. So there's $3,000 on the line here. I think we should have moderators, the best moderator, get some of that money, but I don't think that's going to happen. I wish we had the Jeopardy music to play along. How long do we give them? What are the LJ? You gotta at least be my. We're supposed to be texting at the same time as we're entertaining the audience while everybody votes. I
Yeah,
think
trying
we
to
can
set my
all,
timer.
I think we can all agree that all of these presentations are just excellent. Y'all blew it out of the water as residents. We're so lucky to have you all to help us with projects and to be the next generation of voices here. So I'm hoping next year to see more presentations on not all implants all the time, you know, maybe some female sexual medicine topics, maybe some LGBTQ plus topics. We're going to get them in there. The more research we do, the louder we're going to get. LJ, you talk so I can put my votes in.
Yeah, so, we do want to thank everybody, all the residents for participating, all the audience members for joining. This is our first time trying out this post-meeting virtual resident presentation. We're really hoping to really promote the residents and try and get more of an audience compared to usually at the meeting, everybody's trying to get somewhere, trying to get out to dinner, trying to get to something else. But we're hoping to really promote the residents and get awareness out.
That's true. There was a single medical student, Janice Owens Walton, the amazing medical student who snuck in. No, she's so mature and well-researched that nobody knew she was actually a medical student and not a resident. So she snuck in just in the nick of time. And we're so happy she was here. It provided such excellent work. And we love Dr. Sharita King, my fellowship sister, who just does amazing work down in Georgia. Dr. Yaffe says everything should be virtual from now on, and we should never be in person again. Maybe many people are saying what great moderators we are, Dr. Hannon and Dr. Jenkins. So maybe we can get a television show or something like that. Ooh, I see the results. All right, I'm not picking the winners here. Someone else is going to have to pick the winners. I think we agree with these, huh?
Oh, yeah.
Wow, the winner for you guys. I'm impressed. All right, Tessa, give us the last three. Tessa, put it all together. We've got our votes and the audience votes. This is very, very exciting. This is a lot of money on the line. And Dr. Rayblatt is here, most importantly. Paulina Rayblatt, the most incredible human, is here on this webinar. All right, who's going to announce the winners? The residents look nervous, actually. I see a few beads of sweat going on. I think since Dr. Hannon introduced all of us, and she's the basic scientist, she's good with numbers and statistics.
And the abstract committee chair.
And the abstract committee chair. So I think there's no better human on earth to tell the winners than Dr. Johanna Hannon.
I would be happy to. I'm trying to confirm who our top three is. We've got a top two and we're working on the third.
All right, Dr. Jenkins, what was your favorite part about being live at the SMSNA this year after 2 years of being virtual and in sweatpants and Zoom videos?
I mean, I think everybody can agree that seeing everybody in person, being able to get out the house and just kind of mingle, it's so much different mingling in person than it is over these Zoom chats. These Zooms can be a little bit impersonal.
That's true, but we can say happy birthday to Dr. Jesse, whose birthday it is today. So everyone can give a big happy birthday to. How old are you, Dr. Jesse? You don't have to.
30.
Wow, it's a big birthday.
Right. I'm not supposed to say that, but it's a big number, so I had to.
I feel like she should get $1,000 for her birthday, but it's not up to me.
Please.
It's not just up to me. So I agree with you. Okay, we've got the winner.
We're ready to go. Dr. Jesse, you almost share a birthday with Dr. Bivalacqua, whose birthday is tomorrow. So everybody can go on Twitter and wish Trinity a happy birthday tomorrow.
Trinity never answers any tweets. So
I was going to say, I want to tell you how old he is. He's like 28, right? All right. So what you guys have all been waiting for, in no particular order, 3 people are going to leave here $1,000 richer this evening. All right. So the first one is Dr. Raj Benvadia for his artificial urinary sphincter data. Congratulations. And our next winner, again, in no particular order, is Dr. Rohan Bala for the impact of health literacy and its importance in inflatable penile prosthesis surgery. And last but not least, our final winner of the evening is the birthday girl herself, Dr. Erin Jesse. Congratulations. She spoke on the cost analysis of online telehealth platforms for testosterone therapy. So I'd like to thank all of our speakers. It was a really tough decision. You guys all gave fantastic presentations. And I would like to thank our audience, for all the participants, for joining us. We had a really great turnout, and I think that this was truly a fantastic way to share and convey and celebrate our residents. And I'd also like to thank Dr. Rubin and Dr. Jenkins for helping me moderate this session. And if you guys have nothing else to share, the SMSNA office will reach out tomorrow to our 3 winners to follow up. So you guys will get the check in the mail.
Thank you so
Congratulations.
much for everything. This is awesome.
Yeah, it was a great experience. Thank you.
Thanks, everybody. I think this was a great format. We should definitely do it again. Thanks, everybody, for joining. Bye, everybody.
Good night.